So first we have Dr. Divya, who is going to talk on VKH syndrome, spectrum, inflammation and beyond. Dr. Divya is an expert vitreoretinal surgeon at Givdar Eye Institute, Kochi, and she has won many prestigious awards. So over to you, Dr. Divya.
A warm good morning, everyone. Okoyanatki harida. So it is a multi-system disease manifesting as bilateral granulomatous panuveitis, and it is a disease caused by T-cell mediated autoimmune response targeting melanocyte-rich tissues. So it is primarily or precisely mostly a choroidal stromal inflammatory disorder. As we have shared antigen pools in the choroids and mostly uniform distribution of melanin associated antigen, the disease is always bilateral. So this is the classical presentation. The patient will be coming to you with bilateral sudden onset vision loss. There will be multiple serous retinal detachment, multifocal. There can be optic disc edema or hyperemia and multiple yellowish white subretinal lesions or precipitates. So OCT can be a key diagnostic factor. There will be multilobular subretinal fluid. Enhanced depth imaging will show a huge choroidal thickness. Sometimes even with the enhanced depth imaging, the precision of the choroidal thickening can be challenging because of its huge thickness. And there can be subretinal septae, RPE undulations, and whenever there is a subretinal fluid during acute inflammation, the photoreceptors can be split along the myoids junction. The photoreceptors split between this, it is called as the Ballard or the bacillary layer detachment. And dye tests are diagnostic. There will be hyperperfused areas corresponding to the choroidal infiltration. There will be multiple pinpoint leaks and subretinal fluid, subretinal pooling, and hot disc or the early leg disc leak, what is called as hot disc, which is characteristic. And as the harida, it is a primary stromal choroidal disorder. The hyperperfused granulomas can be clearly delineated in ICG more than that of an FA. So even though variable, the prognosis of the VKH is generally fair, provided there is early initiation of high dose of immunosuppression, adequate duration of immunosuppression, and absence of recurrent inflammation. So this is the same patient. The patient had a counting finger 1 at presentation, and after that with 6 months of immunosuppression, the patient is still sustaining with 6/9 vision. So there is light at the end of the tunnel. So keeping this in mind, what is if there is an atypical VKH presentation, presenting a 52-year-old female, acute painless vision loss isolated to left eye, right eye was completely asymptomatic with a visual acuity of 6.6, left eye had a visual acuity of 560. There was no significant medical history or past history pertaining to the disease. And the fundus examination, right eye was within normal limits, but left eye show multiple serous detachment and multiple yellowish white subretinal precipitates, and OCT show multifocal serous detachment with Ballard sign, and EDI showing a huge choroidal thickness, and the fundus fluorescein angiography showing pinpoint leak and the pooling, and the ICG showing hypoperfused choroidal granulomatous region. So this is the fellow eye of the same patient. At first glance, the multimodal imaging appeared entirely normal. However, on the closer scrutiny details, I will be dealing in the next slides. So this patient was treated with IV methylprednisolone and for subsequently oral prednisolone tapering over 6 months with closer follow-up of the fellow eyes. And she had complete resolution of the serous retinal detachment, visual acuity had improved, no recurrence of inflammation till date. So the fundus examination also you can see there is a complete resolution of the subretinal lesion and detachments. And this is the case 3, but quite young female, a 26-year-old, presenting with acute painless vision loss isolated to the left eye, but her left eye visual acuity was 160, right eye was normal with a visual acuity of 6.6. And this is the picture, a huge multifocal subretinal detachment with OCT also showing the same, enhanced depth imaging show a huge choroidal thickness, multiple subretinal loculated fluids, and unfortunately we don't have a ICG of this patient, but fundus fluorescein angiography showing pooling and multiple pinpoint leaks. This is the fellow eye which appears to be completely normal. And after immunosuppression therapy, even this patient responded very well back to 6.6 vision. So keeping this in mind, we had a series of 15 cases. Me and my mentor, Dr. Mahesh Gopalakrishnan, had presented this in the uveitis forum in the U-Retina. But this has sparked an intense discussion, particularly around the viewpoint that unilateral VKH doesn't exist biologically, it merely escapes a clinical dictation temporarily. So, what in its presentation may appear to be unilateral, the underlying pathophysiology can be bilateral, presenting a significant diagnostic challenge. So, these are two different cases. So this diagnostic challenge, how can we tackle it? Only by clear scrutiny of the multimodeling imaging. So the two clinical cues can be the ICG angiography and the EDA, enhanced depth imaging of the SDOCT. So these are the two eyes, fellow eyes of the involved, the other eye of the patient, that is other eye of the HARADA involved eye. So these patients had, on the clear scrutiny on the ICG, you can see multiple hypocyanescent lesions. It is better delineated in the black on white images. So in this eye, you can see it is very subtle. It is very difficult to delineate the hypocyanescent lesion, but the black on white images, you can clearly see this hypocyanescent lesion. And one more clue is the enhanced depth imaging. Even in the other eye, you can see that the choroidal thickness is large. These are the two representative images of the same. So the choroidal images being large, and even though clinically silent, the ICG is showing hypocyanescent spots. This is another patient, the involved eye and the uninvolved eye. If you see clearly, or if you examine it clearly, you can still see this hypocyanescent multiple choroidal spots, which is clear even in this filters or on the black on white image, and the enhanced depth imaging showing the huge choroidal thickness. So one more thing that has aborted the disease process might be the early immunosuppression. That is, these patients might have presented to you early and you have aborted this disease process with early aggressive immunosuppression. So there are clinical benefits of timely aggressive intervention. It can also prevent the chronic evolution and recurrent inflammation. But the story is not yet over. Long-term monitoring is definitely needed for the confirmation. There are a lot of case reports like unilateral VKH has again evolved with recurrent episodes of inflammation. So coming to a conclusion, the VKH, the pathophysiological reality can be bilaterality, and early aggressive immunosuppression is paramount. So the key questions is like, if there is something like a unilateral VKH, or it is clearly a misnomer. Thank you, ma'am.
Thank you for that presentation. And it's a question that has been hanging around for a while. Like you said, I think you should not label VKH as, by definition it is bilateral. Even the Sun criteria says it is bilateral. So usually you may have one eye which is slightly worse than the other, but it's usually bilateral in presentation. So I don't think you should label something as VKH without doing ICG. This is absolutely not negotiable. I think ICG is must before labeling something as unilateral VKH. And when you do ICG, you very often see that the other eye, there is involvement. The other thing, I want everybody to be cautious about is bacillary layer detachment is not unique to VKH. It's seen across a spectrum of disorders. And one of the other things, which people confuse with a unilateral, VKH is a multifocal choroiditis. And the way to differentiate the two clinically is that the MFC lesions, their size varies. Okay, the VKH lesions are kind of more uniform, and the distribution varies as well. So we don't see people doing a lot of V-scan these days, but VKH is a pan-choroiditis. It affects the entire choroid. So any quadrant you check, you should have an RCS thickening. Whereas the multifocal choroiditis, only that portion will show RCS thickening. Okay. And this is very important, yeah.
Also, in case of unilateral such a presentation, what are the other conditions we should be thinking about?
Yeah, like I said, one is multifocal choroiditis. You need to rule out tuberculosis. Posterior scleritis, yeah, you need to rule that out as well.
But in multifocal choroiditis, do you get that multifocal serous detachment, ma'am, in
You
OCT?
can, in some cases, yes.
Okay.
Yes.
And also in a unilateral VKH, I think the history of trauma
Yes,
should be
sympathetic,
ruled out
yeah.
because sympathetic ophthalmia is a very important condition to rule out. Thank you, Dr. Divya.